these guidelines today have much more clinical trial-based evidence than guidelines from 10 years ago, even if it is a rare disease. And we have introduced in the first line a more refined application of standard tools that existed so far.
Welcome to EHA Unplugged, the official podcast channel from the European Hematology Association, EHA. I am your host, Isabel Olivera. Today, we're talking about the recent ESMO-EHA guidelines for peripheral T and natural killer cell lymphomas. This is a collaboration between ESMO and EHA. To walk us through these guidelines, we have today two professors, Francesco D'Amore from ESMO and Massimo Federico from EHA. Professor D'Amore is a clinical professor and chair of the Department of Hematology at Aarhus University in Denmark, and Professor Massimo Federico is a senior professor of medical oncology at the University of Modena and Reggio Emilia in Italy. They were both deeply involved in shaping these guidelines, and they are here to help us understand what's new in these guidelines, why these changes matter, and how they can make a difference for patients. Thank you for being with us today.
Thank you for your invitation.
Thank you for invitation.
We're going to start by clarifying which lymphomas are in this guideline that uses the term PTCL to cover malignancies that are derived from either T or NK cells. There are many subtypes. What is covered in this guideline?
These guidelines cover the different peripheral T-cell lymphomas that are classified as nodal, extranodal, and leukemic disseminated. We did not cover the topics of cutaneous peripheral T-cell lymphoma.
We did not cover the pre-thymic either, that is the T-cell derived acute lymphoblastic leukemias and lymphoblastic lymphomas. So it is the mature entities post-thymic with the exclusion, as Professor Federico just said, of the cutaneous one among the mature entities.
And why was there a need for these new guidelines?
The last guidelines that the community received in this context were produced in 2015. A decade ago, landscape of peripheral T-cell lymphomas, TNK cell lymphomas, was significantly more simple. So there has been an increase, a dramatic increase in complexity due to steep growth of knowledge in these entities, knowledge about their biology, which also has led to the definition of new entities. As we take, for example, the breast implant-associated anaplastic large cell lymphoma, was something absolutely absent in the latest guidelines. In the latest guidelines, we were talking about intestinal T-cell lymphomas that were enteropathy-associated type 2, which we called it enteropathy associated, but there was no enteropathy around. Today, this has changed the name and has also a completely different biology and background from the well-known and celiac disease-associated T-cell lymphomas. These are two examples of brand new things, and there are many more to mention that make the complexity level of these guidelines much more difficult to see and to understand if you don't have specific guidelines looking at all the entities.
In addition to the clarification of Professor D'Amore, I would like to also underline that we did our best to offer practical guidelines for more than a dozen of different subtypes, just to help physicians to find correctly the guidelines for the single patients. So it was really a huge effort to offer detailed information on how to treat nodal, different types of nodal, extranodal, different types of extranodal, and so on. And this was one of the most relevant reasons for the need of an update.
The first problem, I imagine, is to diagnose these lymphomas because there are so many subtypes and they are rare. How to diagnose today? What are the recommendations in this guideline?
To begin with, as the answer of this question, we have one of the most recognized T-cell lymphoma pathologists as a member of our author group, Professor Delaval, that has produced quite detailed overviews and algorithms for the diagnosis, which is based on a 3 level tier diagnostic approach. The first level is the morphology. The second level is the immunohistochemistry as we are used. But then there is a third tier, which is the molecular profiling at genomic level, which today has entered the diagnostic area, no longer as a research topic, but more and more interacting with the daily diagnostic decisions. So the genomic profile, for example, in TFH, follicular helper, T-cell derived lymphomas will allow you to make decisions in the first line and relapse setting, for example, for the use of hypomethylating agents that are no longer only for research, but also introduced in the daily practice today. So these are new things that the guidelines from 2015 did not have at all.
And so I would also add that we did our best. We tried also to clarify the complexity of the initial diagnosis, so the needs for confirmation by an expert pathologist, and also the need to have a multidisciplinary approach in planning the treatment according to the subtypes and the extension of the disease. But also we would like to help physicians to treat their patients in the area of residency of the patients. So it's a rare disease. Now, it is impossible to imagine that we can cover with a referral center everywhere. So we have to also to try to combine the needs for a correct diagnosis and the needs for the treatment not so far from the area of residency of the patients. And this is an effort of the group to clarify what is essential, first level, second level, third level, the need for discussing the diagnosis, the suspected diagnosis at the referral level, and then offer the opportunity to treat the patients as close as possible to their residency. So it is not so easy, but so we're trying to do this.
But it's not something that the guidelines can go and organize in the text, because there is such a heterogeneity of realities out there, and these are guidelines that are read across the world, are global guidelines. Although they're European in origin, they will be read in the Americas, in Asia, in a global fashion. So it's difficult to come and organize things that are extremely heterogeneous. It is a rare disease. It is a difficult disease even for experts. And if you have to be treated, firstly diagnosed correctly and then treated, it is important that, as Professor Federico said, it is important that a person with experience is looking at these things, and a group, a team, a multidisciplinary team where it is possible to have it is there, because that offers the patient a possibility of survival which is significantly higher than if you are treated standard of care in some kind of disciplinary local environment. So with respect, with the huge difference that there is not only in countries but areas of the world, this must be said about these diseases, because they are very difficult. We had recently a meeting in Asia in different countries. It's extremely different how diagnostic and interpretation is depending on the region you're talking about.
So the big challenge is diagnosis. But then, can you summarize how these guidelines approach the treatment in first line? Which are the main points you want to highlight?
Yes, the first line is, of course, something that needs as much evidence as possible. We work in these guidelines with levels of evidence and in the recognized international terminology. And as you can imagine, in diseases that are rare, there will never be the big trials with hundreds or thousands of patients like you have in some other sections of oncology, like breast cancer or colon cancer. This is a rare disease, so there will be small trials. The evidence will be relatively weak, and we have to work with that. But these guidelines today have much more clinical trial-based evidence than guidelines from 10 years ago, even if it is a rare disease. And we have introduced in the first line a more refined application of standard tools that existed so far. The use, for example, of a CHOP backbone. CHOP is an abbreviation for cyclophosphamide, hydroxydonorubicin, vincristine, and prednisolone, with or without the addition of etoposide, with or without the use of a stem cell transplant of some kind, autologous or allogeneic. But these things were also mentioned a decade ago. What is different is that it is a refined mentioning based on recent clinical trials, based also on world evidence from registries, population-based, and also from experience with long-term follow-up. So this refinement is something that we didn't have in the past. We have looked at, for example, etoposide has been a long discussion in the community, but the guidelines now say we know that etoposide has time after time shown an effect in ALK-positive ALCL. It has been shown in prospective trials, and it has been shown in several retrospective analyses. So you can say that the use of etoposide in ALK-positive ALCL is not just at the same level as the other entities. ALK-positive ALCL seem to have a predilection, seems to have a specifically good response compared to the other entities. So this is what I mean by refinement of what we told people 10 years ago.
In first-line therapy, what we clearly tried to do is to offer the opportunity to select the right management, the right approach according to stage of the disease and histologic subtype. And when is better to use CHOP plus etoposide, when adding novel agents like brentuximab vedotin in anaplastic large cell lymphoma setting, and also the more appropriate approach for offering a stem cell transplant at the end of induction therapy in those entities where it is clear that this could be of benefit, although we are still lacking prospective randomized clinical trial. So just for summarizing this aspect of first-line therapy, first, the panel suggests to consider patients for enrollment in clinical trial. Second, in terms of standard care, those people that like to check for our guidelines, we have 3 figures summarizing the flow chart for patients with nodal, extranodal, and leukemic disease. So we offered a lot of opportunities to try to find the right place for selecting treatment for the patient.
So just to mention on the transplant, we have trials that have been published 1 year ago, 2024, showing, for example, the randomized trial run in France and Germany, the AATT trial, published in 2021 in Blood, and then again now in 2024 with a long-term follow-up. This information with a comparison between autologous and allogeneic transplant in the frontline setting was an important information for the community, because you could see and confirmed in both the final analysis of 21 and the long-term follow-up of 24 that what you gain in terms of better duration of response with an allotransplant, in other words, less relapses, lymphoma-related relapses, you lose in terms of transplant-related mortality. So there is a toxicity from the modality which has less relapses, at the end of the day, they balance each other completely. So there is no difference. So this information is important for the community. And this is another example of applying things at the right time, the right thing at the right time. The guideline ends up, if you have a transplant eligible patient saying, well, transplant should be autologous in the upfront setting where you still have the allo option in the relapse setting to salvage your patient if the patient relapses. So this is a quite important message from the guideline, which is sustained not just by a gut feeling, but by a randomized trial that has been published in Journal of Clinical Oncology just 12 months ago.
Is there anything you would like to highlight about the second line, so the relapse setting?
Yes, so we started from the knowledge that so far the outcome of patients with refractory or relapsed peripheral T-cell lymphoma is usually dismal. So there is a need for improvement, and the guidelines also offer the best evidence on the new agents that have to be considered for patients with relapsed or refractory disease, together with the best use of autologous stem cell transplant and also other innovative approach. But probably Professor D'Amore already can just underline some specific benefit of new agents in specific subtypes of relapsed T-cell lymphoma.
I want to just wrap up around the approach of the stem cell transplant, that in the guidelines, you will see autologous transplant applied to frontline approach with some notable exceptions. For example, the hepatosplenic T-cell lymphoma and the monomorphic epitheliotropic intestinal T-cell lymphoma, the mitral, those two, we recommend allogeneic upfront. Otherwise, most of the others, nodal and extranodal, will be a recommendation of autologous. Whereas in the relapse setting, all chemosensitive patients that are transplant eligible are recommended treated by allogeneic transplant. This is a major pattern. And for the leukemic entities that we have in these guidelines, we didn't have them 10 years ago. If they are chemosensitive in the 3 aggressive entities, then we recommend to treat them or consolidate them with allogeneic transplant. In the relapse setting, one comment is also a new trend surging significantly in the field of T-cell lymphomas, of the importance of minimal residual disease. We know minimal residual disease from leukemia, we know it from mantle cell lymphoma, we know it even for diffuse large B-cell lymphoma. It is a topic that is more and more usual in these discussions. But for T-cell entities, it has been a challenge also in this field, because the T-cell receptor rearrangement, clonality, has not been easy to demonstrate. But today, the tool of circulating tumor DNA, ctDNA, really taking speed and increasing in publications. I just came home from a meeting a few days ago. There was a huge publication that shows patients we call incomplete remission with standard of care tools today, which is the PET-CT scanning, metabolic complete remission. Almost half of them that are called CRs by PET-CT, they still have minimal residual disease if you look at it with MRD. So actually in CHOP-only treated PTCL in that publication, at the end of the day, 29% of the patients treated had a MRD negative status at the end of the treatment. So what I'm saying is we will learn in time already, not in time, but it's already there. It's already now. We will learn that MRD will give us new way of approaching the disease, because what we have been calling CR until now is maybe not CR.
Is this already in the guideline, the MRD? And
we just mentioned it, but ctDNA will be one of the 2 topics, in my opinion, that will dominate the update of the next guideline. If you ask me what will happen for in the next guideline, what do you expect to be the new hot topics in the next guidelines? And of course, in guidelines, you cannot have publications that are so recent that you need more confirmation. You need third publication that shows the same. So it takes a little bit of time. Guidelines will always be a little bit the breaking news of the field. But I think the next guideline will contain it.
So there's this concept of living guideline.
Yes. Yeah, it is necessary. Otherwise, they become like dinosaurs. They become like some stone in past, which is very interesting to see from an archaeological point of view. But if you have to work with that every day in your clinic, then you would like to have something more living. And the NCCN has done that. We try to do the same.
Exactly. One of the aims of this group of people supported by ESMO-EHA is to update guidelines as timely as possible. I don't know if we will be able to do twice per year or 3 times per year or once in 2 years. However, once we will have relevant information coming from research, being clinical trials or other biological news, of course, Francesco and all the group is in agreement with discuss the opportunity to create an update or to inform the community that there are news compared to the already released guidelines. This is very important.
It must be also easier by the collaboration between ESMO and EHA to keep updating these guidelines to join the efforts.
It's good that European societies show they can work together. And it is the first time in T-cell lymphomas, but if you look at myeloma, they're just been published, the ESMO-EHA myeloma guideline. Common guideline. So there are good examples and other that are continuously produced. Get back to your question about relapse refractory disease. The guidelines also have caught some of the very, very new publications about novel drugs that have been clinical trial based. And just to anecdotally for this podcast, I can tell you, we got the results of the clinical trial, the SPIRIT trial, by Professor Tai that published that in Lancet Hematology in the summer of 2000. And it appeared in Lancet Hematology, actually, I think it was 1 week or 2 weeks before we had to send the manuscript out in external review. And we said in the group, well, we would like to have this publication mentioned. So it was very last second we caught that bus and put that publication in our references. And it is a treatment of extranodal NKT lymphoma, that is a typical nasal type lymphoma, present in Europe, but more frequent in Asia, where the use of checkpoint inhibitor, which is a novel drug in the context of NKT lymphoma, that it has a unique favorable effect, combined with the usual asparaginase containing regimens. So if you add upfront, actually, this trial was upfront, first line. It came on top of results that we already had in small phase 2 trials in the relapse setting. But this upfront trial with overall response rate of almost 80%, that has been completely new in the field. So I'm very happy and a little bit proud that we had this publication included at the last minute in these guidelines.
So, Professor Federico, what would be your takeaway message for the audience?
The most important recommendation, in my view, is when you suspect to have a patient with peripheral T-cell lymphoma, please check for a correct diagnosis. This is first. If you are not all the facilities in your area, please connect with centers that can help you in confirming or not confirming the diagnosis. This is the first step. Now, correct diagnosis will translate in the best opportunity to offer the right treatment and the best options for cure. So the second is, if you have a patient with a confirmed diagnosis of peripheral T-cell lymphoma, consider the opportunity to enroll the patient in a clinical trial. Third, if you have to offer just a standard of care, please follow the guidelines we have recently released. In my opinion, they have one of the most relevant efforts to help physicians to make the right decision for the patients.
And I ask the same question to you, Professor D'Amore. What would be for you the takeaway message for everybody to go and read this guideline? Because it's a very complex subject. We cannot cover the whole thing in one podcast.
Yeah, I would say to the reader of the guideline, the recommendation how to read the guideline is, please, if you mean it seriously, then read the guideline in its entirety. Read the main manuscript, but read also the supplementary of the guideline. The supplementary is only supplementary because there is a limit of words from the journals. The things in the supplementary are important things, particularly in T-cell lymphomas, where we have so many entities, and particularly the very rare entities that many physicians feel a little bit shaky about because they maybe have not seen such a patient ever. So my recommendation is please read the entire guideline. In my opinion, you have not read the guideline if you don't read both the main manuscript and the supplementary. As a recommendation for what to do to your patient with peripheral T-cell lymphomas. As it was said by Massimo, by Professor Federico, the importance of trying to put patient in a clinical trial is just because what happens in a clinical trial is that you have more precision about what's going on. You gather information, you have a monitoring of your patients, and those that have looked at it, there are some interesting studies done on plus-minus clinical trial within a certain disease. And there is a difference in survival. Not because the clinical trial was the best clinical trial in the world, but the fact that the patient is monitored and is carefully followed, that makes it less likely to have complications that come maybe suddenly without anybody expecting it, and also a better care of the patient. So there is an advantage to have a patient in a clinical trial. But the problem is, and any reader of the guidelines will of course agree, that if there is no clinical trial, which is the most frequent situation you are in, then the recommendation to bring your patient in a clinical trial is not so easy. And sometimes you can get a clinical trial, you have to send your patient out of the country. And that is also a little bit heavy for the patient and the family. But that would be best. And we have highlighted that in the guidelines. And importantly, that disciplines talk together. So it is important to have a tertiary center. I know there will be different realities around the world, but this multidisciplinary approach from pathology in one end to clinical intervention in the other end, our treatment will never be better than the diagnosis we are offered from the diagnostic side. If the diagnosis is wrong, our treatment will be wrong or not appropriate. Yeah.
Mm-hmm. So I have the impression in this particular guideline, the first key aspect is really a correct diagnosis, because there are so many entities. And from what I could see in the guideline, also each entity is treated in a different way, in a slightly different way in any case. So it's key to go and look at all the details and be precise.
So, you have a heterogeneity here, which is practically unseen. I know there are variants in mantle cell lymphoma. There are variants in diffuse large B-cell lymphomas. But these are biologically completely different diseases. If you think about a lymphoma arising from a breast implant and a lymphoma arising from a patient with celiac disease in the small bowel, these two diseases are so far from each other. Okay, they derive from T-cells, but they are two complete different planets.
So is there anything else you would like to add for the audience?
My wish is to ask the audience to use the guidelines, and in case they need some more explanation, contact us, and we will do our best also to clarify.
Right. And I would say to the audience, stay tuned for ctDNA and combination of new drugs. And combination of new drugs, HDAC inhibitors and EZH2 inhibitors, both oral. So that is just some teasers for the next guidelines. Okay, Isabel, thanks a lot.
Thank you to the audience for listening. And if you enjoyed this episode, please like it and subscribe to our channel. Stay tuned for more episodes of EHA Unplugged.